A hysteroscopy is a minimally invasive procedure using a lighted fiber optic endoscope inserted into the uterus transcervically through the cervical os to look inside the uterus. This procedure can be done for diagnostic reasons just to see what's going on, or it can have an operative purpose to treat a disease or symptoms. Operatively, a resectoscope can be used or they can do an endometrial ablation. Regardless of the procedure, the uterine cavity is infused with liquid air or a viscous, thick media in order to distend the endometrial cavity to see inside. A distension media must be used during a hysteroscopy to visualize the uterine cavity. The media can be gaseous or liquid. If it's a diagnostic hysteroscopy performed, then CO2 can be used for very short cases. Normally, saline or lactated ringers can be used for longer procedures. Both of these liquids are electrolytic. That means that the monopolar current electricity would be dispersed through the fluid and might burn the patient. So these fluids should only be used for diagnostic procedures when the bovie is not in use. If an operative hysteroscopy is performed, glycine or sorbitol is the common fluids used. These are both non-electrolytic fluids that are safer to use when the bovie is utilized. Other less common non-electrolytic fluids are glucose, mannitol, and dextran. Fluid is the distension media most often used in the operating room to insufflate the uterus during a hysteroscopy. This method is usually employed with continuous irrigation through a 1000 ml or 3000 ml bag of proper fluid. The fluid is usually delivered to the hysteroscope by gravity flow from an IV pole or through some sort of pump. The pump can be single pressure cuff bag as seen in the picture on the left, or a more complicated pump as the picture on the right. There's a responsibility of the surgical tech and the circulator to keep track of the rate of flow and the amount of fluid that goes in and out of the patient. Fluids can cause risk of embolus, fluid overload, severe hyponatremia, which is low serum sodium levels, and even death. So it's very important to keep track of the fluid intake and output. A hysteroscope is usually a 4 mm scope that is attached to a light source and insufflation tubing. The tube depends on which type of distension media is being used, either gas or fluid. The most common viewing angles are the 0° straight scope and a 30° offset scope. The hysteroscope is inserted into the sheath prior to the insertion into the uterus. The main channel is controlled by stopcocks, except the accessory instruments. These instruments are usually 2 or 3 mm and include such instruments as grasping forceps, biopsy forceps, or scissors. The main channel is fitted with rubber gaskets that prevent backflow of distension media. The double and single channel sheaths are available. This will make a lot more sense when you're out in clinical and you see them on a case. An intrauterine resectoscope is used to remove polyps, subcutaneous leiomyomas, and uterine adhesions. It can also be used to ablate the endometrium and treat abnormal uterine bleeding. The resectoscope contains 0 or 12° scopes that's inserted into a separate sheath. A spring-loaded mechanism in the handle retracts and exposes the electrode tip. The loop-shaped electrode shaves and coagulates when activated. As tissue is removed by pieces from the uterine wall, it remains free-floating in the media until flushed away from the uterine cavity. Loop resectoscope are that it can both shave and coagulate tissue. Endometrial ablation is the coagulation of the endometrium of the uterus to treat uterine bleeding that cannot be controlled by hormonal needs. The goal is to destroy and scar the endometrium to render it non-functional. The patient must be past the point of wanting to become pregnant to have this procedure. Endometrial ablation can be done with a roller ball that just treats areas of the lining of the uterus, or globally that reaches all areas of the endometrium. Global ablation uses radio frequency and heat.